Hello, how are you all?
We're good. How are you? Thank you.
I'm
Hello,
good,
Dr.
thank
Taha.
you.
We're good. And you?
I'm good, thank you. That's good to hear. Okay. So before we begin, right, and hopefully more people will join in. So before we begin, I just want to give you a quick rundown of all the topics that we'll cover. We'll try to cover as many as possible today, and then hopefully we can also cover a few topics tomorrow. So we'll do pharmacology and all the medications that are important in neurology. So there are 12 different classes of medications. We'll start with the anticonvulsive medications. We'll go to the depressants, so benzodiazepines and barbiturates. We'll talk a little about insomnia medications. We'll talk about triptans, which are abortive medications for migraines, Parkinson medications, other neurodegenerative medications, anesthetics, local and general, also neuromuscular blocking agents. Then we have one medication which is not a group, just one medication, which is dantrolene. Along with that, we'll finish up with some muscle relaxant, opioids, and then glaucoma treatment. So don't worry, I know this sounds like a lot of classes of medications and it's a lot of medications, but I'll try to break it down for you so that it becomes very easy. And these medications, they're surprisingly easy to remember. So let's wait for a couple of minutes, maybe like 2 or 3 minutes, and then we can start with the explanation for all these medications. So if you guys have any questions before then, so you can ask them right now. Okay, so let's start. So firstly, we have these anticonvulsant medications. Now, simply based on the name, anticonvulsant, what kind of condition do you think these medications treat?
Epilepsy.
Seizures,
Yeah.
seizures, epilepsy.
Seizures, epilepsy, any kind of convulsive disorders. Majorly, we'll try to classify these as seizures. Okay, and we know that in seizures, there's two major types. You have focal seizures, and then you have generalized seizures. Now, there is one special classification. It's present in focal, but then we need to talk about it differently because this is a very specific medication which works here. And this is absence seizures. Okay. So now these are three different classifications of anticonvulsant medications. Medications which will only work on, sorry, medications which will only work on focal seizures, medications which will work on general seizures, medications which work on absence seizures, and medications which work on both of these together. So now let's try to figure out what these medications are. The first medication is one which you would have heard the name of a lot. It's called phenytoin. Yeah? And phenytoin, how it works is that it is responsible for the treatment of very focal seizures. So let's say they have a focal seizure, it's not generalized, only one part of the body is being affected. or one specific region of the brain is being affected, you want to give these patients phenytoin. And a lot of times for the step one, they won't really ask you when to give the medications. Like they give you a condition and they'll ask you, okay, what medication do we want to give this patient? No. Instead, what they'll give is they'll give you a presentation. Maybe it's a generalized seizure, maybe it's a focal seizure. And based on this, they tell you that, okay, we gave this patient some kind of medication. Maybe they give you a mechanism of action. And they'll ask you, what kind of side effects would you expect? Or they could do it reverse. They can give you the side effects and they can ask you, okay, what kind of symptoms will you expect in these patients? Or what medication did you give this patient? So phenytoin, right, treats focal seizures. And a few of the side effects, right, are first one, important to know that it is teratogenic. And what does teratogenic mean?
That can cause birth defects.
Like pregnant women cannot take it.
Yes, pregnant women cannot take it. And that is one of these questions that they'll try to trick you with. They'll tell you that a pregnant woman with seizures comes into the clinic and they'll tell you, okay, the patient is taking some kind of medication. So, like, you can already imagine that, okay, maybe this is phenytoin, maybe this is carbamazepine, which is also teratogenic. And now you've already narrowed this down simply by knowing that these medications can cause a teratogenic effect. Well, that's the first symptom that we want to know. Now, second symptom that we want to know is something called as DRESS, DRESS. And DRESS is basically a system-wide like hypersensitivity reaction because of drugs. So very bad. You'll have like a full allergy blown reaction, not good. And interestingly enough, right, both of these side effects, teratogenicity and DRESS, they're similar for all of these anticonvulsant medications. A lot of them have these side effects.
Sir, can you kindly repeat this dress? I did not understand.
Yeah. So DRESS, think of DRESS as a systemic allergic infection to the medication. Now, this would present with eosinophilia. You'll have a lot of spots. So it could also present with rashes, a systemic allergic reaction because of the medication. That is DRESS.
Okay. Thank you.
Yeah. Now, these are two important side effects of phenytoin. And interestingly, these are the same side effects which are important for another medication, which is called carbamazepine. Carbamazepine can also cause a teratogenic effect. Carbamazepine can also cause DRESS. One more interesting thing is that both of these medications, they have a similar mechanism of action in that they block sodium channels. So now you might be thinking, okay, both of these, they're pretty much the same side effects, pretty much the same mechanism of action. So how can we differentiate between these? And for that, you need to remember two side effects which are specifically associated with carbamazepine. The first one is actually agranulocytosis. And what do you guys think agranulocytosis means?
Absence of granulocytes as your
Yes, absence of granulocytes. That's why you see it's an A. A means no, then granulocytes. So that just means, there is no granulocytes in the blood. And along with this, it can also cause aplastic anemia. Okay, now let's say there is a patient who has agranulocytosis. What is the first infection that you're thinking about in these patients?
Recurrent infections.
Infections, yes, 100%. Agranulocytosis will give the patients some kind of immunosuppressant state. And this immunosuppressant state will lead to multiple different infections. However, there is one infection that the USMLE does want you to remember very well, and that is Pseudomonas. And do you know why they ask about Pseudomonas?
No, why?
No. So because Pseudomonas has a very specific type of like medications that you want to use. So I can give you an example, right? Sometimes they might use this kind of strategy. Yeah. They might tell you that patient has a seizure. Okay. You gave the patient some kind of medication. Now patient has an infection. And then they can ask you, okay, which cephalosporin? So what do you think would be the answer to this one?
Either ox, clox, diclox, or NAF.
So which
Methicillin sensitive sepoias. I'm sorry, piperacillin, tazobactam, those things.
oh, sorry, I wasn't able to hear your voice. Sorry.
Sir, basically you are saying that
What's the
the
question?
patient would just present with some kind of infection and they will ask that which cephalosporin was given to him.
Yeah. So oh, okay. So let's break this question down. Right?
Cefepime.
This patient had, oh yeah, so this is ceftazidime. Okay. Yeah, so multiple different medications you can give, but here, they tell you a seizure. So this could be, let's say, a focal seizure. Okay. Then you give the patient some kind of medication. Now, simply based on focal seizures, we can say that this might be phenytoin or carbamazepine. Because they've given us infection, now you're leaning more towards carbamazepine. Why? Because of agranulocytosis. And then based on agranulocytosis, we said that patients might develop a pseudomonal infection. And then based on this pseudomonal infection, the cephalosporin that we should give is ceftazidime. Obviously, you can give other cephalosporins, but ceftazidime is what the USMLE is looking for. So now see, any one of these things, they could either give you the type of seizure, or they could give you the type of medication used, or what kind of infection did the patient have, or what medication was given to treat the infection. And simply based on any one of these four facts, you can make the differential between what medication was given. So that is how they'll present these questions. Okay. So after this, we have a different kind of medication. So we had phenytoin and carbamazepine, which both block sodium channels. And now we have a different kind of medication which blocks calcium channels. And these are the gabapentins. And we said this blocks the calcium channels. For gabapentin, you need to remember that gabapentin majorly is used so it can be used for focal seizures, that is good. But gabapentin can also be used for neurological pain. And now, what kind of patients do you think will present with neurological pain?
Amputees.
Amputees, okay. What else? Let's say a patient is obese, maybe has some kind of obese is diabetes, yeah. Could be type 1, type 2.
Neuralgia.
Trigeminal neuralgia too. But this is actually interesting that you bring up trigeminal neuralgia. For trigeminal neuralgia, the most important medication would be carbamazepine.
Post-herpetic neuralgia.
Yes, for obese people, the herpetic neuralgia can be.
Yeah. So a lot of things, but majorly remember amputees, they can have like neuralgia, and this is because of like phantom sensation, phantom limb sensation. And the other would be diabetics. Diabetics can develop long-term neuropathic pain. There is another medication that you might know which can be used to treat neuropathic pain. But do you guys remember which other medication can be used?
No, sir.
So this one, think of a TCA.
Amitriptyline.
Yeah. So you can use amitriptyline, or you can also use nortriptyline. Additionally, I heard someone also say duloxetine. Duloxetine is also one. Now, here, because we're talking about TCAs, there is also, yes, gabapentin, obviously. So here, because we're talking about TCAs, there is a important thing that we need to say. And I will mark this as a start so you guys don't forget this. You do not give, okay? You do not want to give depressants you do not want to give depressants to elderly. Yeah. Why do you think we should not give depressants to elderly patients?
Increases risk of suicide.
Risk of suicide, not the psychiatric depressant, but think more along the lines of a like CNS depressant.
Can increase the risk of fall.
Can predispose them to delirium.
Risk of
Yeah.
fall.
Oh,
Okay. So one is delirium. Also, someone mentioned a risk of falls. This is also very important. And also, so I would say these are the most important. But depressants, because you can also depress heart rate and also respiratory rate. So basically, you can also like completely depress the cardiovascular and respiratory systems, and that is very bad because you want the patient to be beating. You want the patient to have a beating heart and to have the patient breathe. But okay, another branch point here with falls. So if a patient falls down, elderly patient, what are we afraid of?
stomach.
Bone fractures.
Hip fracture.
Yeah.
Bone
Hip
fractures,
fracture.
yes. Head fractures, yeah, that's true.
Fracture.
But what is very severe?
Hip fracture.
Hip too. Yeah, hip fractures is very important. They can fall down, they can break their hips, but also, so I will write down hip fractures is very important. But with a hip fracture, patient might patient wouldn't be able to walk very well. Patient would be in a wheelchair, but patient still survived. The more severe one would be a subdural hematoma.
Yes.
Yeah.
Yeah. So that is why you don't want to give depressants to patients, elderly patients. Now, also for delirium, and do you guys know what kind of medications can cause delirium? Or what I would say
Benzoid.
molecule?
Antihistamine.
Yes.
Benzoid. The benzoid.
Benzoids too, antihistamines, anything which
Anticholinergic.
yeah, anticholinergic. Okay, I'll just write the abbreviations. So anticholinergic medications. You said benzos, that can do this too. Thirdly, we also said H1 blockers, so antihistamines. One more medication that we should add here is TCAs, because TCAs have a very powerful like muscarinic effect, and that can lead to delirium. So now we're left with a problem here. We said that patients with neurologic pain can receive TCAs, but elderly people should not get TCAs. So now we can't give them TCAs. Or do you think we can still give them a TCA?
We cannot give them.
Yes, normally we cannot give them a TCA, but that specifically applies to something called as amitriptyline.
Okay.
So we do not want to give amitriptyline. So that I'll mark this. Oh, that okay. So we do not want to give them amitriptyline. Instead, we can give them nortriptyline. So this is important that you can give patients nortriptyline even if they're elderly and have neuropathic pain. Elderly patients can receive nortriptyline. Won't be your first line choice, but certainly something to consider. Okay. So any questions until now?
For elderly, we can say 60 years and above.
Yeah, more. I would say more than 65.
Okay, thank you.
Okay. So, sorry. Yeah. The next medication we want to talk, very easy medication, that is ethosuximide.
Well, sorry, what are the side effects of the gabapentin and the neurological
Oh,
pain?
so GABA. Oh, sorry. Oh, wait, give me 1 second. I accidentally just removed everything. Okay. So gabapentin and sorry, gabapentin and the pentagabalin, both of these medications, which work by blocking the calcium channels, they can cause sedation, and that's the worst kind of side effect. And that's why I wanted to put this topic here. So gabapentin, TCAs, they can cause sedation, so they can lead to an increased risk of falls. They can also lead to an increased risk of delirium in elderly people. Normally, if you're like young, healthy, then there's not much that they'll do, but they can lead to sedation in elderly, and that is what you need to remember. Yeah. So, any more questions about what we've talked until now?
No, sir.
Okay. So the next medication that we'll do is ethosuximide. Now, ethosuximide, it's very easy. You don't need to remember any side effects. There are only 3 things you need to remember. Ethosuximide blocks calcium channels, and it is used for the treatment of absence seizures. That is all you need to remember about ethosuximide. Very simple things. Ethosuximide blocks calcium channels, is responsible for treatment of absence seizures. And now, how do absence seizures present?
They just stare off into the
Like
Yes.
in the case.
Sometimes it can only be one of the hands shaking.
Yeah. So
They
it's a
can have
focal seizure.
The feeling only.
autonomic symptoms, but no post-ictal state.
Okay. Now, I would like you to think about the classic presentation. For absence seizures, the classic presentation would be a child staring out into space, or they might have a slight hand tremor. But it's a very focal seizure, would not affect the entire body, only like one specific portion of the entire body. Yeah. So those were all the medications which are used for narrow spectrum, or like the focal seizures.
Can I ask
Now,
a question?
yeah.
Sorry, what teratogenic effect does the first one phenytoin cause exactly?
So phenytoin.
What specific teratogenic effect, like what does it cause? Like, is there any specific, or should we just know it's just teratogenic?
Think about
That's a neural defects. Yeah.
yeah. So the teratogenic effects that you'll see with phenytoin. Think about a cleft lip, a cleft palate. It's also called a and someone will have to correct me. I don't think I'm pronouncing the name right. Fetal hydatid syndrome. Oh, actually, someone wrote it.
Fetal
Hydatian. Yes, Hydatian syndrome. Yeah. So it will be
Thanks,
a lot of deformities with the face. Cleft lip, cleft palate, maybe some misplaced teeth, all of these things. That's actually good. I will write this down. Yeah. Thank you.
So,
Okay.
doctor, it presents with the cleft palate and also some other abnormalities.
I'm sorry, I wasn't able to hear you. Your voice was very muffled.
Yes, actually, I'm saying fetal Huntington syndrome is presented with the cleft lip palate and like the facial dysmorphicity or some other also abnormalities.
Oh no, so it's a collection of like things together. So you will have someone with cleft lip, cleft palate. Maybe they have some kind of facial deformity. Maybe it's like a so a smaller like face. Maybe micrognathia would be present. maybe you have some misplaced teeth. It's a full syndrome. So multiple different things. And phenytoin will cause fetal Hidatian syndrome. And one more thing, right? If they ask you a very broad like question, they don't really give you any specific medications, but they just tell you that patient has a seizure and what is the baby at risk for, then you want to think about a neural tube defect. If it's very non-specified, that what the medication is. And do you guys know what vitamin can we give for the prevention of neural tube defects?
Folate.
Folate.
Folic acid.
Give folate. Okay. Now, the next medication that we were going to talk about, and these are called the broad spectrum medications.
Doctor, is it
Yeah.
gingival hyperplasia with phenytoin? Is it being told? Because I have come late.
Oh, yeah. So gingival hyperplasia is also present in phenytoin, except for these. And you can remember them, but then I would always tell you that remember these as more important for differentiating between carbamazepine and phenytoin. So the agranulocytosis and aplastic anemia, it is easier to remember these because you can assume that, okay, both of these are with blood. So if you have to make a differential between phenytoin and carbamazepine, you can just think that carbamazepine has more blood type of side effects. The agranulocytosis, aplastic anemia, both of those. But yeah, there are multiple things. Phenytoin can also have gingival hyperplasia. You could also develop like folate deficiency, which will then give you like neural tube defects instead of fetal Hidatian syndrome. So multiple different things. Along with, so those were all the like narrow spectrum medications. Now we have the broad spectrum medications. That means these medications, they work on both focal and general seizures. Yep. So both of these. And the first medication that we'll talk about, that medication is valproate. And you know, one very interesting thing about valproate is actually the most dangerous medication for neural tube defects. Also, we say that valproate can be used for treatment of seizures, both focal and general. So can you tell me another condition that valproate can be used for?
Bipolar or depression? Depression.
Yeah,
Bipolar
bipolar.
Sorry, bipolar.
Bipolar disorder. So bipolar disorder is also important for valproate. And now, you know, you might be thinking that, okay, bipolar disorder, both of these medications, so valproate and lithium, both of them, which are very good for treating bipolar, both of them had teratogenic effects. So which one should I give the patient? And the idea is that whichever medication the patient is more stable on, that is the medication you want to give. That is for valproate.
Sorry, please can you repeat yourself? You said whichever medication the patient is what?
Yeah. So whichever medication. So for the treatment of bipolar disorder, right, there are two medications that you can give, which work really well. Either you can give the patient lithium, or you can give the patient valproate. Now you see, both of these medications can cause teratogenic effects. So you might be thinking, okay, which one of these medications should I give if both of them have a risk of teratogens? And then the idea is that you want to give a medication which the patient is stable on. So any medication, let's say the patient is stable on lithium, the patient has not had a manic episode for, which are not suited for the patient, but more that this patient hasn't had a manic episode in over 2 years while being on lithium. That is what stable is. So there is no relapse of the condition. And whichever one the patient is stable on, that medication you want to give. Now, valproate is a very interesting like medication because it blocks everything. Yeah, remember, it blocks everything. Sodium, yeah, it blocks it. Calcium, yeah, it blocks it. GABA, yeah, it also blocks GABA. So it blocks all of these different things. So multiple different things. However, one very interesting thing you need to remember is that valproate has two very nice side effects. The first one is pancreatitis. The first one is pancreatitis, and then the second one is actually weight gain. Both of these for valproate. Now, I have one interesting question, branching question. What kind of necrosis do you see in pancreatitis?
Fat necrosis,
Fat necrosis, and maybe another one?
coagulation, liquefaction, yeah.
Yes.
Liquefaction.
So I'll mark a small star here. Just
Liquefaction.
add that pancreatitis can cause both necrosis. The actual pancreas undergo liquefactive necrosis, and then the actual fat surrounding the pancreas undergoes a fat necrosis. Yeah, so two different type of necrosis that can be present with pancreatitis or pancreatic necrosis. Okay. Now the next medications are, there are two very similarly named medications. You have lamotrigine, and then you have levetiracetam. Levacetam. I should check the spelling for this. I'm not sure. Yeah. But lamotrigine and levetiracetam. Now, these medications, right? The only way they'll ask you about these medications is in one very specific context. But these medications are good for children. These medications are good for childhood seizures, and that is very important to remember. They might also go with, okay, what is the mechanism of action? And the mechanism of action is also very similar in that lamotrigine, it blocks. Okay, there's only three things, one of three things it can block. Do you guys want to take a guess what it might be?
Sodium.
Sodium.
Sodium. Okay. So lamotrigine blocks sodium, and then levetiracetam, that is different because it blocks something called as SVA. And what SVA is basically means synaptic vesicle protein. So synaptic vesicle protein A, that is why it's called SVA. And basically the synaptic vesicle protein A is the protein which is responsible for pushing something into the synapse. So it makes a vesicle which then goes into the synapse. So it's responsible for blocking this specific molecule. And then there is not much that you need to remember about these medications, except for this part. Very important to know. Okay. So now there is another medication which is called topiramate. Now, the most important thing you need to remember about topiramate is that this is a medication which can cause weight loss. There is only two medications which have weight changes. One is topiramate, which causes weight loss. And do you guys remember which medication can cause weight gain?
Valproate.
Yes, valproate. Perfect. Now, in addition to causing weight loss, this medication might also cause kidney stones. Now, it's not really understood why it causes kidney stones, but then that is one very rare side effect that the USMLE likes to test you on. That, they'll tell you that someone came in with multiple seizures, you gave them a medication, and now they have a flank pain radiating to the groin. And you're thinking, okay, this is a kidney stone. And which medication causes kidney stones? Topiramate. And then remember that topiramate, it blocks sodium channels. So any questions about these anti-epileptics or anticonvulsants?
No, sir.
Perfect. So many medications, right? But don't worry, we'll try to get through them. We'll try to review them once too. So don't worry. By the time we're done, hopefully all of you would be like really good with all of these medications. The next
Doctor, I have
classification
a
that we have.
question.
Yep.
With limotrigine, which is good for children, what type of question can they ask us with this type of?
So,
for
a
children?
majority of these questions, they would be based around the fact that you need to differentiate if the patient is having a absence seizure or if the patient is having a focal or a generalized seizure. Because if the patient or the child has a focal or generalized seizure, then you want to give them lamotrigine or levetiracetam. But if they're having an absence seizure, then you're leaning more towards ethosuximide. So that will be the majority of questions that they'll frame.
Okay, doctor, thank you.
No problem. Now let's go with two of the most widely used, or I mean, they used to be widely used, medications in neurology. These are benzodiazepines versus barbiturates. Okay. Now, there are multiple different like mnemonics that you can remember. One of them works on frequency, one of them works on duration. So the way I remember it is just that barbs, they work on duration, but you can use any mnemonic that you remember. And then benzodiazepine or benz works on frequency. Okay. And both of these, the frequency and the duration, they're changing for the chloride channels. And where are these chloride channels, or like what are these chloride channels associated with? They're associated with the GABA receptor. So basically, what these medications do is the first one, benzodiazepines, they'll cause the GABA receptor or the GABA, the GABA receptor to open multiple times. And when it opens multiple times, because a lot of chloride will go out, then that's why you'll have like depression of the CNS. On the other hand, barbiturates, they'll just increase the duration that the GABA receptor is active and the duration for which the chloride channels are open. And then that will lead to CNS depression. Now, one of the most important things, right, is that for differentiating between these two, is that barbiturates, the most important to remember is that barbiturates are more dangerous. Mark it with like a big star. And why are these? Oh yeah, I was saying that the most important thing to remember to differentiate between benzodiazepines and barbiturates, except for the duration and frequency, is that barbiturates, they're more dangerous. And now, why are these dangerous? Because barbiturates can cause a massive depression of the CVS and the respiratory system. So much so that sometimes patients who have a barbiturate use can develop a respiratory rate of only 2 breaths per minute. This is how low it can go. And that is extremely dangerous because the patient is just very close to dying. So you want to avoid barbiturates as much as possible. Also, you want to avoid benzos as much as possible because they're very addictive. But benzos you can still use for certain things. Barbiturates you want to avoid as much as possible. Now, remember I told you that both of these medications. So remember I told you that both of these medications, they're responsible for causing depression of the CNS. Okay, both of these are responsible for depressing the CNS. So now, what kind of conditions would they be used for? where you actively want to depress your CNS.
Seizures like status epilepticus.
Seizures, okay.
Mhm.
Seizures, status epilepticus. Okay, these are possible.
Intubation.
For intubation, okay.
Aggression.
Aggression,
Insomnia.
anesthesia, insomnia, maybe something else.
Anxiety as well.
Anxiety. Oh, sorry. Anxiety, alcohol withdrawal,
Panic
Panic
disorders. Panic attacks. Mhm.
panic disorders. So see, there are so many different uses of benzodiazepines. So many uses. So then let's just do one thing. We'll add a small note here. Multiple uses. But now, why is it that even though benzodiazepines have so many uses, even though they have so many uses, we want to save them only for a certain amount of people? Why do you think so?
dependence.
Yes, dependence and abuse. Benzodiazepines can very quickly cause dependence. And once someone is dependent on them, once they develop tolerance, they're very and very highly likely to be dependent, and they'll have like a drug addiction very quickly. So you want to avoid benzodiazepines, but they are important. So you should give them, but avoid as much as possible. Okay. So see, that is the difference between benzodiazepines and barbiturates. So any questions for these two medications?
No, sir.
No. Perfect.
Doc,
So,
Doc, how
yeah.
how would you classify benzodiazepines and barbiturates? Are they broad spectrum or like another different class of it?
Oh no, so they're just two medications. You don't classify them as anti like convulsives. They're just CNS depressants. So they are CNS depressants. That means they activate the GABA receptors, which then changes the chloride, and they cause overall depression of the CNS. So that's why they have so many use cases, because a lot of problems that happen in the brain are because of overactivity. Seizures are because of overactivity. Aggression is because of overactivity. Insomnia is because of overactivity. Anxiety, alcohol withdrawal. Okay, that's not because of overactivity, but I mean, okay, if you have withdrawal, then you can have overactivity. Panic disorder, that is because of overactivity of the brain. So benzodiazepines or barbiturates, they try to reduce this overactivity by overall depressing the CNS.
Okay, got it.
You know, I would like to change my answer a little. Alcohol withdrawal, yes, that is also an overactivity of the brain, because alcohol is a depressant. And then when you have a withdrawal from a depressant, you have a simulated or like a sympathetic response. So patients would be more like stimulant during the withdrawal. Yeah. So alcohol withdrawal is also a hyperactivity state. Okay. So now we have again three medications. Three more medications, and these medications are for sleep. So basically insomnia. Insomnia. These are three medications for insomnia. Now, if I were to tell you guys, okay, tell me a random sleep medication, what is the first medication that comes to mind?
Help.
Which one?
Alprazolam.
Oh no, so not the benzodiazepines. Maybe something else.
It's
Zolpidem.
melatonin.
Melatonin. Yes.
Or Zolpidem.
Melatonin.
Zolpidem.
Yeah, I mean, okay, there are multiple medications, but melatonin, it's so widely used, right? So widely used. And the other name or the medication for melatonin is Rimeltian. Yeah. And then how does melatonin work? It basically helps by just give me 1 second. So the way melatonin works, right, is that melatonin, it helps your body adjust to its circadian rhythm. And do you guys know what the circadian rhythm is?
Sleep.
Morning.
Sleep.
Your
Yes,
sleep and wake cycle. Sleep and wake
Sleep
cycle.
cycle.
perfect. Yes, sleep and awake cycles that your body naturally, adjusts to. And melatonin helps to modify or like keep it in control. And where is the sleep or the circadian cycle located? Or like which part of the hypothalamus is the circadian cycle presented? Influenced by?
Nucleus, I assume.
Yes, suprachiasmatic nucleus.
Yep.
Perfect, suprachiasmatic. And now, in the suprachiasmatic nucleus, there are two different hormones or molecules which are present. One we said is melatonin, and melatonin actually promotes sleep. But what's the other one, which, not promotes, but like avoids sleep or suppresses sleep?
Serotonin.
No, not cert. Think about it, norepinephrine. Norepinephrine. That is the one which suppresses the sleep or the cycle of the circadian cycle. Now, what happens, right, is whenever you look at like the sun, maybe a lot of bright images, you have an increase in norepinephrine. And norepinephrine will then suppress the melatonin, and then that's why you can stay awake. Now, as the day progresses, the level of norepinephrine keeps on going down. And because the level of norepinephrine is going down, that is why you have an increase in melatonin. And then because melatonin is promoting sleep, that is why you sleep. Now, there were a lot of people who also said orexin. Now, orexin, or hypocretin, that is also another molecule which is involved in sleep. And the thing that we want to do is that we want to inhibit orexin. If we inhibit orexin, then patients can sleep more better. So let me write this down. We have orexin. And what orexin does is it promotes sleep. Oh, sorry, suppresses sleep. So if we block orexin, to treat insomnia. Yeah. So if we can block orexin, then we can essentially treat insomnia. And then the medication which blocks orexin, so this one, that is called sevorexant. Sevorexant. Now, there is one very specific pathology in which orexin is implicated. So do you know what pathology that is?
Narcolepsy.
Yes, narcolepsy. So sevorexant, I would say, is good for narcolepsy. Yeah, is it good for narcolepsy or is it bad for narcolepsy? What do you say?
Bad.
Yeah. Yes,
Bad,
Bad.
bad.
Confined.
bad for narcolepsy. And instead, what should we give for narcolepsy then to help them sleep better?
Modern or something like that.
Yeah. Okay. So
Benzo.
in the not benzos, not always benzos. So in the morning, you want to give them some kind of stimulant. So that is modafinil. That's one. And then in the evening, what do you want to give them? This is a very special substance, and that is called sodium oxybate. So these are the two medications that you want to give to patients with narcolepsy. In the morning, you give them a stimulant. At the night or in the evening, you want to, give them a depressant so that they can sleep better. So that is for orexin, sevorexant, bad for narcolepsy. Actually, not even bad. I would rather say this should be contraindicated. Okay. Now, the next medication that we have is what you guys mentioned a lot, the non-benzodiazepine sleeping medications. So, non-benzo sleep medications. And what were the three that you guys were mentioning?
Zolpidem,
Okay. Zolpidem,
Zaleplon, and one
Zel-
more. Zaleplon, Zepiclone,
Zaleplon, and
Zepiclone.
okay, I'll tell you one interesting thing. The third one doesn't start with a Z. It actually starts with an E.
Yes, Zopiclone.
Zopiclone.
Zopiclone. Yes. And what do we need to remember about these medications? That these medications, they also act on the GABA channels, but they are not benzodiazepines. So now, which group of patients should these medications be contraindicated in? You should not give these medications to a certain type of people.
People with liver cirrhosis, liver failure.
Could be liver cirrhosis, but also in elderly, right? Why in elderly? Because it is blocking GABA. So if it blocks GABA, then you know that it will cause some kind of sleep, and then you don't want to give it because you might increase the risk of delirium, you might increase the risk of falls. So much better to put them on something else rather than anything. Yeah. Okay. So you should, I'm not saying you don't want to give these medications, but I'm just saying that give it carefully so that you know that the patient won't fall down, the patient won't have any kind of delirium. And if you can be sure of that, then yeah, sure, give that medication. So these are the sleep medications. So three categories. The most common one, melatonin. Then one which is associated with orexin. So that medication is sevorexin. And then finally, we have the non-benzodiazepine sleeping agents, which also work on GABA receptors. Now, finally, we have this one medication, right? It's only one medication, but it's very, very important. It's called triptan. Triptan. And triptans are actually one of the few medications which can actually help in abortive treatment. The abortive treatment of migraines. Now, why is this so important? Why do you think so? Why is it important to find abortive treatments for migraines? Because migraines are very painful and they're very bad.
They're 5-HT1 antagonist.
Yeah, obviously. So triptans, the way they work is that they block serotonin receptors. Sorry, they are agonist, not block. They are agonist. So they work at the 5-HT1B receptor. Agonist. And 5-HT is actually only medical terminology for serotonin. Now, I have like two important questions. The first one is here, you see, we've added 5-HT1B. So then what is 5-HT2B for? There is another medication which specifically blocks 5-HT2B.
Is it aldosterone for vomiting? I don't know if it's type B or 2.
Which one?
Aldosterone.
Ondansetron. Okay, could be. There is a huge group of medications though. So think antipsychotic medications. Any antipsychotic medications work on 2B?
Fluoxetine, Prozac.
So wait,
Halol?
is not Halidol? Those are D2 majorly. Think about the atypical antipsychotics.
I think it's clozapine.
Clozapine, yeah.
Yeah, so the atypical antipsychotics, not the typical ones, the atypical ones. So here you have clozapine. You also have which one? So yeah, you have clozapine. You also have wait, why am I?
Risperidone.
You have
Risperidone, yes.
You have risperidone. You have quetiapine.
Olanzapine, okay, yeah. So all of those antipsychotic medications, the one which cause more metabolic syndromes, and obviously clozapine. Those are for 5-HT2B. And then the second question I had was this medication, triptans, that is important for abortive treatment. So what are some prophylactic treatment?
Propranolol.
Okay, propranolol. So beta blockers is one. What other medications? Think about calcium channel blockers. Maybe something else.
Sodium valproate.
Valproate could be one. Maybe TCAs. So multiple different medications which you can use for prophylaxis. There's only a few for abortive treatment, and out of them, the most important one, which we currently use, is triptans. And how do they work? They are serotonin agonists. Now, with relation to triptans, right, there are two conditions where you absolutely do not want to give triptans. So the first one is whenever they have like Prince metal angina. So, okay, I'll just write this. Yeah, so you do not want to give them for Prince metal angina. And do you guys remember what Prince metal angina is?
Vasospastic anginitis.
Yes. Vasospastic. And what ECG changes will you find in these patients?
ST segment elevation.
Yes. So ST elevation. Perfect. And then the second condition is actually coronary artery disease. And let me just write contraindicated. Yeah, so contraindicated. Do not give these medications triptans for any of these. It's in red. I have a star with contraindicated. Do not give these medications. Now, you know what's the reason why they might be contraindicated though in Prince metal angina and coronary artery disease? Why do you think they're contraindicated?
Because I think they
Exacerbate.
constrict.
Yes, they can cause constriction. And the way they cause constriction is again because of spasm. So they'll cause a vasospasm, which will then lead to like a constriction. That could lead to ischemia and a lot of bad things. So you just want to avoid triptans for anyone who has coronary artery disease, or the patient has, let's say, Prince metal angina, which is also called vasospastic angina. So you really want to avoid these medications for them.
You can repeat last point.
What?
You can repeat last point.
Oh, yeah, sure. So the way you can, sorry, not the way, but the reason why triptans are contraindicated for Prince metal angina and coronary artery disease patients is basically because triptans can cause vasospasm. And when you have vasospasm, you'll have a constriction of the artery. So when you have constriction of the artery, the myocardium doesn't receive a lot of blood. you could have ischemia, you could have an infarct, all of these bad things. And that is why you do not want to give patients who have these conditions any triptans.
Can I ask a question?
Yeah, sure.
I don't know if it's a valid question, but the 5HT1B agonist or 5HT2B, which one is more associated with, would you say is associated with serotonin syndrome?
I'm not sure if there is a specific one which is associated with serotonin syndrome.
Or
I
both?
think serotonin syndrome is because you have such variety. So when you have a lot of serotonin, when you have like excessive serotonin, it will just go bind with everything. And that is why you have such a variety of symptoms in serotonin syndrome. Rather than just activating one receptor, when you have more, it will activate all of them.
So can this triptan, which is an agonist of serotonin, can it also lead to serotonin syndrome?
Yes, serotonin syndrome can also be possible because ultimately it is also serotonin. And for serotonin syndrome, you just need more serotonin, not specific. Even if it is specific, if you just have more serotonin, it will give you serotonin syndrome.
Thank you. Okay.
Yes.
Doctor, I just have a question. Sorry. You just said about the triptans and then you talked about the prophylaxis where you said propanol, calcium channel valproate. Yes.
Yeah.
So I want to know that these medications are for the prophylaxis of migraine.
Yes. Prophylaxis for migraines.
Okay, thank you.
Oh, I'll write this a little better. So we have migraines. Okay. So we'll end this here for triptans. And now let's go back to our list of medications. So how many medications did we cover? We covered the anticonvulsive medications, we covered benzodiazepine and barbiturates, we covered the insomnia medications, we also covered triptans. So see, it doesn't look like we've covered a lot, right? But it feels like we've covered so much. But don't worry, the remaining medications, they're more easy and they're much smaller. So don't worry, by the end, so we have more time today. So we have a little more time today. And then we'll also do some medications tomorrow. So by the time we're done, we'll have completed a majority of all of these different medications. So now I would like to tell you that what we'll do these two medications, the neuromuscular blocking agents and then dantrolene, so that we have more sense that we've completed half of all of medications. Because Parkinson's is a little big, so we'll try to complete these two. What do you guys say?
Yes.
Perfect. So let's do that. And then in the meantime, let's take a quick 5-minute or 2-minute break. I'll also drink some water. And then let's continue. So 5 minutes and we're back.
Thank you.
Okay, so you guys ready? Let's start with our neuromuscular disease or neurodegenerative disease medications.
Yes, sir.
Okay. So neurodegenerative medications. Okay. So now there are three conditions, right, where these medications will work. And each condition has a different medication. The first condition is Alzheimer's disease. Okay, that's the first one. The second one is actually ALS. And then the third one is Huntington's disease. Okay. So these are these are three conditions where a few of these medications would fit. Okay. So the first one, for Alzheimer's disease, you 100% need to remember that for Alzheimer's disease, there are three medications which you 100% need to remember. These are called donepezil, the lantamir, and then rivastigmine. These are very important medications. And now you see rivastigmine, it has the stigmine suffix. So what do you think all of these medications are? Like what mechanism of action do these medications have?
On acetylcholine.
Yeah.
Inhibitors.
So ACHE, the esterase inhibitors. Yeah. So basically, what these medications are doing is that they're blocking one specific enzyme, and then this enzyme is called acetylcholine esterase. And what does this enzyme do, acetylcholine esterase?
They break down acetylcholine into choline
Yes.
and acetate at the neuromuscular junction.
Yeah, so it breaks down ACH. So now if we're inhibiting this enzyme, that means ultimately what these medications do is they increase acetylcholine. And that is why they're helpful for Alzheimer's disease, because Alzheimer's, ultimately the problem is that you have a decrease in ACH levels. And that is why these medications will work. And that's why they're so good, because they increase directly the level of acetylcholine. So that's why they're so good. Now, the second medication that we use for Alzheimer's is actually called, it's actually called memantidine. And the way memantidine works, right, is it basically blocks the glutamate channels. Yeah, it basically blocks glutamate. And do you know what kind of receptor does glutamate have? What's the name for that receptor for glutamate?
NMDA.
NMDA, yes. So NMDA. Now, I'll tell you a very interesting thing. Memantidine is actually from a similar class of medication as amantadine. And do you guys know what amantadine was used for or is still used for?
For the Parkinsonism disease.
Okay, yeah, it can also be used for Parkinson's, but then, it also found its root somewhere else.
Antiviral?
Viral, yes. So it was used as an antiviral medication. And do you know which virus it used to treat?
Influenza virus.
Influenza, yes, influenza. And I remember that there is some question, yeah. I don't remember where exactly is it, like NBMEs for step 1 or 2, or if it's UWorld for step 1 or 2. But they do ask you, there is a question where they say that there was a patient with Alzheimer's disease who got a medication which has a similar class as an antiviral medication. So which medication is this? And then you're thinking, oh, wait, antiviral, that this does not make sense. But then you're like, oh, maybe this could be memantidine or amantadine or something similar. And that is why I want to tell you this important fact. Initially started out maybe as an antiviral. Then we found out that, oh yeah, this is also very helpful for patients with Alzheimer's or patients with Parkinson's. That is why this medication is important. Now, obviously, because these medications, about these medications, right? Now, because they're increasing acetylcholine, if you were to give like excess of these medications, then they can lead to a cholinergic problem. So very careful with those. That is for Alzheimer's medications. Two different types. We have donepezil, rivastigmine, galantamine, these three, and then we also have memantidine, which blocks NMDA receptors, which are also the glutamate receptors. Now, the next type of medications we have is again an NMDA blocker. So basically, this means that this will decrease glutamate. And this medication is called riluzole. And they're for the treatment of ALS. Now, I'll tell you one very interesting thing about neurons, right? What happens with neurons is that when a single neuron dies, maybe because of, not single neuron, it doesn't have to be single, maybe a small group. When a small group of neuron dies because of, let's say, starvation, maybe they don't get enough oxygen, maybe they don't make enough energy. When they die, all the neurons, they'll start fighting amongst themselves. So each neuron will try to release as much glutamate as possible so that their surrounding neurons die, and then that one neuron stays alive so that it can use more of the energy to stay alive. This condition, where each neuron produces glutamate to kill off all the surrounding neurons, that condition is called glutamate induced hyperactivity. Very important condition to know. And remember that this is mediated by glutamate. It's almost like neurons are the med students in the match. They're all fighting against the same position. Yes. But remember that this condition does happen. Glutamate induced hypersensitivity or hyperactivity. And the way we can kind of prevent this is by giving patients riluzole. And this condition might also happen in patients with ALS. So that's why we want to give them riluzole so that this does not happen. And then we can prolong the survival of patients with ALS. Very important. Now, finally, the third class of medications that we have is a bit weird. It's not a very standard medication. More, it's a rather small subgroup. And these medications, they will always have the suffix as benzamine. So let's say benzamine. So this could be, let's say, tetrabenzamine, or it could be deuterabenzamine, any kind. But remember the benzamine suffix. These medications are used for Huntington's disease. And the way they work, it's very interesting. They block a very specific molecule, which is called a VMAT. Now, does anyone know what VMAT is?
Vesicle monoamine transport, maybe?
Yes. So VMAT, actually the full form is vesicle monoamine transport. So transport molecule, transport protein, or you could also just write transporter. Yeah. So now let's break down this word, right? We say vesicle. Now, where is this vesicle? In the neuron. Neuronal vesicle. Monoamine. So do you guys know what kind of neurotransmitter is a monoamine?
Norepinephrine.
Norepinephrine is one. So let's say norepinephrine. Maybe something else.
For dopamine,
So dopamine, maybe something else. Serotonin could be one. So see, multiple different like neurotransmitters and then transporter. And we said that benzamines, they inhibit the VMAT. Yeah. So now ultimately, what they're doing is that they're preventing the release. They're preventing the release of these hormones, sorry, neurotransmitters. They're preventing the release of these neurotransmitters. And that is how these medications work. They prevent the release of monoamine vesicle transporters. So they inhibit VMAT, which then prevents the neuron from releasing these vesicles into the synapse. And that is good for Huntington's disease. Additionally, they can also be given, so along with Huntington's, I can add that they can also be given for extrapyramidal symptoms. Yeah. So these are the two conditions they can be given for. So any questions until now for these three different classes of disease medications that we talked about?
No, sir.
Okay, perfect. And then finally, we will talk about this one very interesting medication. It's one you really need to know because the condition is more important than the medication itself. And this medication is called dantrolene. So dantrolene, right? What dantrolene does is that it blocks calcium channels. Basically, it's a calcium channel blocker. And does anyone know what condition dantrolene is used to treat?
Malignant hypertension.
Malignant hyperthermia.
Yes, malignant hyperthermia. Okay, malignant hyperthermia. Now, what do you think would be the symptoms that you'll expect in a condition which is called as malignant hyperthermia?
Increased
temperature.
Yeah.
With heart rigidity.
Increased rigidity. Okay. Maybe something else.
Temperature, hypothermia.
Yes. Okay. So high temperature.
Hypercapnia.
Hypercapnia. And what is a simplified, like, let's say, word for
Increased
hypercapnia?
CK.
Increased CK. Okay, so we say hypercapnia is increased CO2. And then you also say that, okay, yeah, increase CK, so creatinine kinase. I'll write CK here. And then we can say that you have increased CK because of muscle breakdown. Yeah, so because of muscle breakdown. And now, why do you think we have hypercapnia, which is increased CO2?
Is it because of sustained muscle contraction?
Yeah, so sustained muscle contraction. And if, let's say, you have a diaphragmatic, if you have a diaphragmatic muscle contraction, sustained, then that is how you can increase CO2. Because now you won't be able to breathe properly. So that's why you have more CO2. Now, so now we know like what would happen with symptoms in malignant hypothermia and what we can use for treatment. So we give dantrolene, which is a calcium channel blocker. And sorry, if you want to be more specific, it's a ryanodine calcium channel blocker. Yeah, right. Oh, sorry. Yeah, a ryanodine calcium channel blocker. It doesn't allow me to write it here, so I'll just write here. A ryanodine calcium channel blocker. Now, finally, we have only one thing remaining for malignant hyperthermia, and that is, what is the cause of malignant hyperthermia? And that cause of malignant hyperthermia is primarily anesthetics. And majorly, we can say that it is caused by inhaled anesthetics.
Inhaled anesthetic.
Yes, inhaled. Oh, sorry. Inhaled anesthetics. Now, what are the different types of inhaled anesthetics? What are anesthetics? Maybe local ones, maybe general ones. That we'll study tomorrow. So this is a good cliffhanger that we can start from anesthetics tomorrow. So any questions, guys? Any questions on all of these topics that we did?
No, sir.
No. Okay. Perfect. So then what we'll do is that we will continue tomorrow. Hopefully we can, hopefully we complete all of these. So we have some opioids, we have some muscle relaxants. We're going to start with anesthetics. Oh, I think I marked this a little wrong. We completed the neurodegenerative disorder medications. Yep. Not 8. Yeah. So we've completed half the medications. I hope you guys feel confident with half the medications from the nervous system. And now we will start tomorrow with the remaining half. So I hope to see you guys tomorrow. This would be probably before the marathon. No, not the marathon, the boot camp. And I will see you guys tomorrow. Thanks so much for attending. Really enjoyed teaching you guys.
Thank you so much, Dr. Taha.
Thank you.
Thank you so much.
Thank you so much.
Thank you.
Thank you.
Hello. Thank you so much, Dr. Taha. Please don't leave the session. We have some important announcement to make. We have a big news, and we are going to share another link. Please do join that link. We have a big news. We are going to share that. Kindly join another link we are sharing. Okay.
Okay, thank you, sir.
Okay.
Okay, that's it.
Okay, I'll share all of these tomorrow once we have the entire completed PDF.
Okay.
Okay. See ya. Goodbye.
Okay, so let me just mention again, please join the meet. We are going to send meet. We are going to announce some news regarding UWorld, and please just do join that, right?
Yes, doctor. Yes.